there's been a seismic change in our healthcare system here in the United States and globally as well. But this change didn't just happen overnight. It didn't just happen because of COVID. COVID has exposed the fragility of our healthcare system, as well as the complexity of our patients. If you think before COVID, if you look at the complexity of the patients we were taking care of, they were just getting sicker and they're getting older. That hasn't changed. For example, if you look across the Medicare population in the United States, there's 5+ comorbidities for any patient that's admitted to the hospital. Now, if you have hypertension, it's not a big deal, but you add hypertension to kidney disease, to diabetes, to renal disease, and so on, then the patient becomes much more complex. And in that same environment, the healthcare environment was starting to limit the resources that we had to take care of our patients. If you think early on in the pandemic cycle, a lot of the issues were around supply chain, which we still have some supply chain issues. But now we're having staffing issues on top of supply chain issues. I think we were really at the brink of collapse, and I hate to be dramatic, but it's absolutely true. The pandemic can serve as an impetus of change. Whenever I'm faced with a new patient as a consultation or in my clinic, and we all do this as healthcare providers, we try to determine their healing potential. We recognize that the wound is simply a sign of the host. And wound healing or wound healing potential allows us some insight on whether a patient can heal or they can't heal. I often use the equation, the healing potential equation, which I derive by just my observations of patients that I'm faced with. The healing potential equation equals 1 in the numerator. In the denominator, there's bacteria, there's perfusion, and there's tissue mechanics. We can impact change on bacteria, we can impact change on perfusion, and we can address the biomechanics of tissue. But I don't think that's where it ends. I think that's where you start. Those are the low-hanging fruit. What drives everything is the host. The host continues to evolve, continues to change, continues to be complex. But on the simplest level, we can count the number of comorbidities the patient has. We need to adapt to the current circumstances. There's always been 3 drivers of healthcare: economics, efficiency, and effectiveness. These 3 E's drive how we deliver healthcare. We know that healthcare is expensive, and in some countries they spend much more than in other countries. For example, the United States leads the globe in healthcare spending. Yet, if you look at the metrics of success of healthcare and how it's delivered to a population, we rank last or dead last compared to other developed nations, even though we spend almost double that of other developed nations. We have to develop ways to provide more efficient delivery of care. And that's the second E, efficiency. The efficient delivery of care not only reduces waste in healthcare spending, but targets different biologics, drugs, or devices that can deliver more efficient healthcare. The last E is effectiveness or efficacy. What that means is we need to challenge our current treatment algorithms, our current uses of device, biologics, or drugs. And you do that in a systematic way. And you do that with good research design. I've watched the evolution and the adoption of negative pressure wound therapy with instillation. I've published a lot in this space, and I've had the opportunity to talk to a lot of people over the course of the last 10 years. And at some point during that time period, there's been some holes in the reason why people weren't adopting it. And going back to the 3 E concepts, economics, efficiency, and effectiveness, there were times when there wasn't enough data to support its efficiency. There were times when there wasn't enough data to support its efficacy. There were times when there wasn't enough data to support its economic argument. Well, that time is gone. If you look at the data, clearly it hits on all 3 E's. Decrease in total cost of care, increase in efficiency, as demonstrated by multiple publications in decreasing length of hospitalizations, decreasing the number of OR visits. And effectiveness, if you look at the clinical outcomes of closure or coverage, it's clear to me that negative pressure wound therapy with instillation has demonstrated those 3 things, and there's no more excuses to not use it.